we've organised this webinar as part of something called NCOR RN, which is the NCOR Research Network. And most of you have probably attended this webinar via being members of the NCOR Research Network. If you have come to this webinar from a direct invitation through Facebook, or someone shared the link with you, you're very welcome, but we'd be really grateful if you would join the Research Network. There's no commitment to take part in any kind of activities if you do so, but there will be lots of opportunities to take part in webinars like today, or to take part in research studies in the future, should you wish to do so. And all you need to do to join the network is to click on that link. I think Jerry's going to put it in the chat as well, where you can scan the QR code with your phone, and it'll take you to a survey. It's a relatively in-depth survey, so I wouldn't start it now. It's probably going to take you 15 to 20 minutes to do. It's going to take lots of information about you, your clinical practice, and we use that to then have an understanding of what our membership looks like, so that we can choose appropriate research to do. And the idea of a research network like this is very much that you, the members, have a say on what research will be conducted as well. So what research is important to you and the challenges you face in clinical practice. So it really does give you a voice in what research NCOR is going to conduct by being a member of the network. So it'd be really grateful if you would join that if you're not already a member. If you're already a member, thank you very much. Okay, so myself and Jerry will be taking the session today. My name is Daniel Bailey. I'm an osteopath in practice, but for a couple of days a week, I'm also a research fellow for NCOR, mainly involved with the research network and the projects that we're running as part of the research network. And then Jerry is also an osteopath in clinical practice. He's director of NCOR and also head of research at Health Sciences University, which was University College of Osteopathy. So, as we've said, we're conducting this webinar today to basically give you an overview of the IFOMPT framework for managing patients with cervical pain, with a view to managing the risk of vascular causes of that cervical pain. And what we as NCOR are doing is we're investigating the guidelines and how well they've been taken up in clinical practice, and then whether this clinical audit process that we're going to do today impacts how those guidelines are adopted. So we're not investigating or judging you as to whether you're adopting these guidelines. We're really investigating the guidelines to say, well, are they any use? Are people using them? What do we perhaps need to do to help people use them if they're not being used? So that's the research that we're conducting behind this webinar. And so we would like you to consent to us to using the information you provide today. And to do that, you can click the link, which Jerry's going to put in the chat. It's on the screen, or you can scan the QR code. This is a really quick one to do. It's literally just name, email address, I agree, and then I think 3 or 4 questions about your practice, so which part of the country you're in, that sort of thing. So if you could just take 60 seconds to do that now, if possible, we'd be really grateful, just while I kind of make some introductions. And then we've got that out of the way. If, however, it's not working for you, don't panic. This webinar is being recorded, and we'll send the links out to you in a separate email at the end of the session, and you can go back and provide that information at a later stage if you need to. But it should only take 30 seconds if you are able to do it now. There will be a couple of other points during the presentation where there'll be a QR code for you to scan to take part in some questioning and discussion. So if you can get that to work, that would be useful just to help you participate, and you will need to be able to access the links to take part in the objective activity. So please feel free to put any issues in the chat, and Jerry can try and sort things out for you. Obviously, you've not got your speakers on, you've not got your microphones on, just because we've run this as a webinar, just because we didn't know how many people there were going to be and how difficult that would be to manage. But you can ask a question by using the chat, or if you prefer to ask it in person, if you put that in the chat, and we should be able to enable your microphone, and if you wish, your camera as well. for you to ask any questions. The webinar is being recorded so that we can share it with the profession for them to use for their own CPD purposes. So bear that in mind if you are choosing to display your camera. We will edit that out afterwards if we do have any situations like that. So hopefully we'll be able to keep you anonymous, but if your question's really interesting, it might be valuable to keep it in. So let us know if you do want to be edited out if you choose to ask a question on camera. As I say, we're going to be collecting anonymous data that we can then use as a research organisation to investigate how effective these guidelines are, how well they're being implemented, and whether clinical audit is a useful thing for osteopaths to do to help integrate frameworks and guidelines into their clinical practice. So hopefully you're having some success with the link. Part of this audit process is measuring change in your clinical practice. So we're going to take a snapshot of what your clinical practice looks like today with regards to the framework. We're going to invite you to make some changes to your clinical practice based on what you discover from the audit today. And then we're going to invite you to re-audit your clinical practice in a few months' time to see whether the changes you made actually had any impact on your clinical practice. And so that is a full clinical audit process, but certainly from what you'll do today, that would be sufficient to qualify as the objective activity requirement for your CPD purposes for GIOSC. So if there are no questions, Jerry, or major issues, I'll move on. So an overview of what we're going to cover today. So I'll go over what the objective activity is. I'm sure most of you will have done that at least once by now, but we'll just recap on what it is we're trying to achieve with the objective activity. And then I'll go through what a clinical audit is and how that fulfills the objective activity requirement and what we're going to be doing for the clinical audit. We're going to identify an issue in practice, which is really the first step of a clinical audit. And so the issue in practice we're going to look at today is patient risk assessment for vascular causes of neck pain and whether the IFOMPT guidelines are useful for us in managing that risk. I will go over the IFOMPT guidelines and pick out all the relevant points and how they can be used in practice. Then we're going to conduct a clinical audit of neck pain patients. So hopefully you've all got access to some case history notes of neck pain patients that presented to you that you've seen. And what we're going to do is firstly, we're going to set the standards. So what is it we're looking for in these case histories? And that's going to be based on the IFOMPT framework. So then we're going to take some measurements. So how did our case histories match up to the framework? And then as a group, we're going to look at those findings. So are there any key areas where perhaps our case notes aren't aligned with the framework? We're not going to be doing that individually. That's just going to be as a group. So no one person is going to be identifiable or no one patient is going to be identifiable. But this is so we can fulfill the objective, we can fulfill the criteria for an objective activity whereby we're getting an external opinion. So by us combining that data, we can create this opinion by using everyone's approach to their management of neck pain patients. We're then going to invite you to reflect on the findings. You'll be able to see your own results without anyone else seeing them, and you'll be able to see where perhaps you align with the framework and where you don't align with the framework. Perhaps you agree with that, disagree with that, and there might be some changes you feel would be useful to make in your clinical practice to help reduce the risk when you're seeing patients with neck pain. And then we'll go through the re-audit. So essentially you'll make those changes. It might be adding an extra question into your case history. It might be doing a particular examination a little bit more routinely with neck pain patients. And then in a few months' time, when you've had time to see some more neck pain patients, we'll invite you to essentially fill in the same questionnaire that we're going to get you to do today. And then as NCOR, we'll compare the sets of results before and after the changes and see whether this was a useful process for you to undertake. So that's what we're going to be covering today. So what is the objective activity? So hopefully you'll be familiar with this. So the purpose of doing the objective activity is to enhance and inform your practice and CPD, but specifically this is through analysis and reflection on the views of others. So this is not just you reflecting on your own clinical activities or CPD. This is using the opinions of others. So this is why we're going to be grouping all the data together from people's neck pain patients today, so that we can compare other people's approaches to inform our own view, analyze and reflect on that, and therefore make it more meaningful in terms of an objective activity. So the objective activity forms one component of CPD. So we've got the objective activity in the blue jigsaw section. You've got to demonstrate CPD from a range of practice. So this is covering all the different components of the OPS. You've got to demonstrate some CPD specifically in the topic of communication and consent. So that must be part of that range of practice. You need to keep CPD records. You don't have to submit these, but you need to keep them. Should you be audited, you would have to submit them. But routine annual submission and 3 yearly submission doesn't require you actually submitting records, but you do need to have them. And then finally, you need to conduct your peer discussion review, which is essentially a chat with a colleague whereby you talk through the CPD that you've done and your plans for future CPD. So those are the sort of compulsory components of the CPD scheme. So we're going to be getting external objective feedback by comparing your approach to the approach of your peers. We're going to be analysing the results of this feedback. So we'll show you what your management looks like and how that relates to the IFOMPT framework. We'll then reflect on that. We'll see where there are gaps, see if those gaps need addressing, and think about what we could perhaps do to address those gaps. And then what you need to do is show that this objective activity informs your clinical practice. So how has it done that, or how will it do that, and how will it change your future practice? So that's those 3 questions: what, so what, and what now. So the what is going to be about the IFOMPT framework. The so what is, well, I can potentially reduce risk with my neck pain patients. And the what now is, well, I'm going to add a question into my case history form so that it always prompts me to ask about this particular area, so that I'm not going to miss it. And then I'll be more consistent in my questioning and hopefully more likely to pick up issues that could suggest patients are at risk of a vascular cause of neck pain, for example. So what is a clinical audit? Clinical audit might be a process that's quite new to people. It probably isn't a particularly sort of sexy sounding activity to perform in clinical practice, but it can be something that can be really useful, partly because you can choose what you do really. But if we try and define it, it's perhaps easiest to define what research is, because research in clinical audit can be thought of as quite similar. So research is all about discovering the right thing to do. So when we're doing research, we're asking the question, what is best practice? What is the best possible way that we could do this for the patient to get the best outcomes, for example? That may involve coming up with a completely new treatment or management plan, whether that's a medication, a drug, a technique, whatever. Ideally, it's conducted on a large scale over a long period of time, so that you have the greatest chance of reducing any kind of errors in your data, and the answer that you get is really the true answer. So that's kind of ideally what research should look like. If we compare that to clinical audit, a clinical audit is ensuring that things are done right. So a clinical audit presupposes that we already know what the right thing to do is. So the IFOMPT framework for managing patients with neck pain is very much research. That was looking at the best thing, or the best way, or the right way to manage patients with neck pain. We're doing clinical audit where we're ideally going to identify whether the best things are actually being done in our practice. And we're using the IFOMPT framework as that criteria to compare our own practice against. So it asks the question, are we following best practice? Are we doing the best things for our patients? Are we minimizing our patients' risks as best we can? Are we providing the best care, best treatment, most effective treatment for our patients? Not what is the most effective treatment, are we providing the most effective treatment? So it doesn't involve anything new. We're not trying out new stuff. We're simply evaluating whether we're already doing the best thing. It's usually done on a much smaller scale, as we're doing today, so it can just be one clinician in their own practice, and it's usually done over a short period of time, so that there'll be a snapshot measurement where you look at what you're doing today, you ideally implement some change, and then within 3 to 6 months, you do another snapshot assessment of whether things have got better, and then you can judge whether that intervention worked, whether what you did worked. So that's the clinical audit process. So it can be done on very clinical things like we're doing today, but you can do it on more administrative aspects, more management aspects, more business success aspects, if that's what you want to do. You know, that process of assessment, intervention and reevaluation can be applied to all aspects of your clinical practice. And so it can be a very valuable activity for your practice, as well as meeting the criteria for your CPD requirements. So exactly what is involved in the audit cycle, it is a very specific cycle. There are various links that we're providing at the end of the presentation, and there are quite a few links on how to conduct an audit and the audit cycle, some general ones and then ones specifically prepared by NCOR. But basically choose something that interests you. So risk management of neck pain patients is something that is of concern to osteopaths. There's quite a lot of CPD in that area, so it's clearly something that osteopaths are thinking about. So we chose this area because it is of interest to osteopaths to minimize the risk to their patients. It needs to be something that you can improve, so something that you have the capacity to make changes around. And so with clinical practice, we do. It needs to be a common problem. Lots of osteopaths are seeing neck pain patients. It needs to have some consequences, so there needs to be reason to be worrying about this and changing it. And clearly, if something poses a risk to a patient, that is a serious consequence. Then what you do is you set the criteria and the standards. So you need to have some sort of benchmark that you're comparing your clinical practice to. And there are lots of guidelines out there, depending what it is you're investigating. We're looking at how we manage neck pain patients, and the IFOMPT cervical framework is probably the most appropriate framework or set of standards to compare our own clinical practice to for this topic. So the kind of thing you're looking at is all patients presenting with a certain condition X should have had X within the past 2 months. So in the NHS, it might be that patients with a certain condition should have had a specific blood test done within the last couple of months in order to manage their condition effectively. That might be the kind of clinical audit that's conducted within an NHS setting. And these are going on all the time. You need to set some sort of standard. So in an ideal world, yes, this standard will be met in 100% of cases, and there may be circumstances where it must be met in 100% of cases, but it might be more realistic that actually we want to make sure that 3/4 of all patients are achieving this standard. You know, that might be a waiting list. So, 75% of patients within A&E should be seen within 4 hours, for example. I've just made that stat up, but that might be a benchmark that is being used, for example. Then you're going to collect the data. So there's lots of ways you might be able to collect the data. If you're using digitized patient notes, something like Clinico, that might be a really easy way to extract data. Might be, cut out a lot of time for you, cut out a lot of effort. Or it might be you have to go through patient notes like we're going to go today. And so you might only be able to use a handful of notes because you're going to have to go through them in more detail. So patient notes, PROMs. So these are patient reported outcome measures. So these are little questionnaires, usually short questionnaires that you can give to patients. It might be measuring their pain, their level of disability. It might be measuring their satisfaction with your service. It could be used for all sorts, but they're validated questionnaires, which means we know that those questionnaires actually measure what they say they're measuring. so that the results can be reliably interpreted, and they can be really useful for measuring all aspects of clinical practice. There's various proms available through the Research Skills Facebook page and NCOR's website. You might be taking the data from patients. You might be taking the data from colleagues, so other clinicians, other osteopaths, other healthcare practitioners that work within your practice. You might be taking it from other staff, administrative staff, reception staff, etc. Once you've got your data, unless you're meeting all of your standards 100% of the time, which is unlikely, you need to then consider why those standards might not be being met. And this could be due to the sort of patients that you're getting into the clinic, or patients not adhering to the treatment advice. It might be colleagues that haven't had the necessary training or haven't got the time to do what it is you want of them. It might be that there isn't sufficient money in place to provide the facilities or the treatment that you're aiming to give. So you need to try and identify a reason behind why the standards aren't being met. See if you can implement any changes to improve that. So what's going to be done? Whose responsibility is it? When is it going to be done? How long is it going to take? And then you choose an appropriate time to do a re-audit, where you then collect more data and then compare that data to the first set of data and see whether things have improved. And this is a constant evolution of improving your clinical practice and to provide the best care, be the most successful clinic, or whatever your goals are. So we're going to be doing it to have a look at whether these guidelines are any good, and whether, well, not whether they're any good, but whether they're actually useful to clinicians in implementing it into clinical practice. So identify the issue, set the standards, measure the data, compare the data to the standards you've set, and then reflect on why you might not be meeting those standards, implement some change, and then measure again. And then you keep going round and round in circles, and each time you go round in a circle, hopefully things are getting better. So that's the audit cycle. If there are any questions, please feel free to just put them in the chat, and Jerry can either answer directly or give me the question to go through. So first of all, we're going to identify an issue. And the issue we've identified is that vascular pathologies can present as neck and head pain. And as osteopaths, we see lots of people with neck and head pain. And so potentially some of those patients have a vascular cause of that neck and head pain. This is fairly high profile stuff. There's not maybe anybody who's not aware of this. Often in the media like to report on how patients have had serious consequences, usually to neck manipulation, usually to chiropractic neck manipulation, which has either left people with serious complications, or in the worst case, people have died as a result of vascular injuries in the cervical region or even in the brain. So this was a relatively high profile one not too long ago. Quite recently there was a BBC programme called Con or Cure, with a fairly well-known TV doctor, one of the twins, and they were quite derogatory about chiropractic in particular, but also about the effectiveness of manipulation. And it's not just chiropractic that's in the firing line. There was a recent six-figure sum insurance payout because of an osteopath's insufficient note-taking or note recording following a vascular dissection event. And that really gets to the crux of the issue, in that the dissection event wasn't the fault of the osteopath, in that the techniques they didn't cause the dissection event, didn't cause the vascular event, but potentially the records that the osteopath made, and by implication the assessment that the osteopath conducted, may have been insufficient and meant that that dissection event could perhaps have been identified before it happened, had the notes been better, which kind of reflects that maybe the examination could have been better. And so that's really where these IFOMPT frameworks, guidelines are hopefully going to help us to make sure that we're doing everything to reduce that risk of an unidentified dissection event occurring. So I'm going to go through the research now on how dissecting events can present. So the IFOMPT framework, for those of you who perhaps haven't seen it, it was a large piece of research whereby lots of data was looked at, combined with expert opinion to create a set of guidelines. They've referred to it as a framework rather than guidelines, but it works as guidelines as to how we should manage patients presenting with neck pain. And it's really about identifying the risk. Steve Vogel was on the panel of experts and has been involved in various publications as a result of that. And he runs a CPD course now with Roger Kerry, who's a physiotherapist from Nottingham, about how manual therapists, including osteopaths, can use the framework and really reduce the risk when they're managing patients presenting with neck pain. But it's helpful to know what the symptoms are. So it's broadly split into two categories: dissecting strokes and non-dissecting strokes. So dissection is where you actually start to get a tear within the lining of the artery, meaning that blood can start to penetrate in between the layers of the artery. It's not that you would attempt to try and differentiate between a patient presenting with a dissecting or a non-dissecting stroke. It's just simply that they do have quite different sets of symptoms and signs that commonly are associated with the two different types of stroke. It's really not that you need to learn the differences between the two, you just need to be aware of all of these signs and symptoms. But I have broken them down into the two different sections. So these are the presenting signs and symptoms for a dissecting stroke. So I've broke it down into risk factors. So risk factors are really what you're going to be trying to extract from the case history, probably in the past medical history section and family history, things like that. Symptoms are obviously what the patient presents with. And yes, it may be that they're presenting with neck pain and headache, but have you asked about other associated symptoms as well? They may not offer that they've experienced visual disturbance, for example. They may not offer that they've experienced dizziness. Can you demonstrate in your case history that you asked about dizziness, that you asked about visual disturbance, because these are quite common symptoms for these patients? So this is where it may be that case history notes are found to be inadequate, because while they report the patient had neck pain, they don't report that the patient didn't have visual disturbances, didn't have dizziness, didn't have paresthesia, for example. So paresthesia, numbness, UEX, let me just get my pointer so you can see what I'm pointing at. So paresthesia is numbness. UEX is short for upper extremity. So this would be a change in sensation of the upper extremity. So what else? We've got dizziness, paresthesia in the face, so numbness in the face. Paresthesia LEX, paresthesia in the lower extremity. So looking through risk factors, OCP, so that's oral contraceptive pill. FH is family history, so family history of stroke. And then looking through signs. So signs are things that you're more likely to actually detect during a physical examination. So these are the sorts of things that should appear in your physical examination section. So unsteadiness, ptosis, so this would be the drooping of the eye. Weakness in the upper extremity or lower extremity, so that might come through your myotome testing. Facial palsy, so weakness in the muscles of the face. Speech or swallowing difficulty, so that may well be something that comes up in your questioning rather than something you examine. But again, have you demonstrated the patient doesn't have speech or swallowing difficulty? Nausea or vomiting, so again, that's more signs and that's more symptoms things you're going to ask about in the case history. Drowsiness, LOC is loss of consciousness, and then confusion. So these numbers in brackets are the percentages of patients who have these symptoms with a dissecting stroke. So in 81% of cases of patients with a dissecting stroke, that they will have a headache. So, you know, a headache is a really important question to ask the patient. Have they had a headache with their neck pain they might coming in with? You know, patients might only think that you're going to care about their neck pain because you're an osteopath and you'll only look at their neck pain, so they might not mention their headache. And if they've not had a headache, you need to write no headaches, so that you can show that your case history, in your case history, that you asked about headaches, because you know that 81% of patients with a dissecting stroke would have a headache. In the signs one, VBAs for vertebrobasilar artery and ICAs for internal carotid artery. So where I've presented two percentages, the first percentage, so weakness in the upper extremity, that would be 33% of people with a dissecting vertebrobasilar artery stroke, whereas 65% of people would present with weakness in the upper extremity with an internal carotid artery stroke. So hopefully that just explains all the numbers. If I've missed any of the abbreviations, or if the numbers aren't clear, please put something in the chat. But hopefully what this table does is it helps you to focus on where your questioning and where your examination really needs to be. So in terms of risk factors for a dissecting stroke, recent trauma is really quite important. So a bang to the head, a whiplash accident, a fall, for example. Recent trauma is really important to ask about. So the potential causes of this neck pain, if it was traumatic neck pain, then that is going to start to give you a higher index of suspicion that potentially this could be vascular in nature. And if you start to build up a picture of somebody with general cardiovascular risks, such as high cholesterol because they're on statins, you know, they're a smoker, they have a family history of cardiovascular problems, they're currently hypertensive, suddenly you're really starting to increase your index of suspicion that there is potentially a non-mechanical cause for this patient's neck pain. So therefore, you might start to ask a little bit more about the questioning of the symptoms, you know, associated symptoms such as the headache, visual disturbance, the paresthesia, so numbness in the upper extremity, etc. And then when it comes to your examination, you may well choose to conduct a full neurological examination to identify for any unsteadiness, you know, difficulty balancing, do your myotome testing of the arms and legs to see if there's any weakness, possibly do some cranial nerve testing for the facial nerve to see if there's any weakness in facial muscles, because these are all the things that are quite common in patients with a dissecting stroke. So the information you gather in your case history will help you to decide what are the priorities when it comes to your physical assessment, your clinical examination. So that's the dissecting strokes.
Dan,
yeah.
Before we move, there are quite a few questions in the chat that I think would be useful maybe to go through now. There was a question whether it was only numbness or paresthesia in general. So, you know, I replied to the fact that it is paresthesia in general that could be, and so I listed all the different types of symptoms that could be described by patients regarding burning, prickling, itching, tingling, and so forth. There were questions around the language to use in our notes, whether we should say things like patient denies ... or shall we say things like patient reports that they have no ... which would be using less negative sounding, and asking what is thought to be best practice at the moment. So I guess it would depend on what we consider being best practice, what are the sort of, you know, criteria. On a legal point of view, these two things would be similar. On a sort of more shared decision making and, you know, co-creation, collaboration point of view, the second form, patient reports they have no, seems to be, you know, giving honest and more trust towards what the patient reports, when the first one might be seen a bit more judgmental, saying that the first one is quicker. So, it's always trying to find a bit of a balance between these things. Pete asked whether these symptoms could be persistent or if they could be intermittent. That is definitely, both possibilities are, possible. Both, so the patients could have either persistent or intermittent presentations for some of the symptoms. So some might be persistent and others might be intermittent. And that's why looking at the sort of cluster of all the risk factors, symptoms and signs all together is giving us much more sense of the potential vascular aspect of the presentation. Someone has issues seeing the slides. I think most people can see the slides. So what I would advise you is maybe to leave the webinar and to come back, and hopefully that will fix the issue. There was a question whether there is a clinical friendly template that we can all use regarding this. And I think that may be something that will come at the end of this presentation around potential changes and things like that. So I think that will be covered probably a bit later. That's all, but I thought it would be useful maybe to do all of that. Sorry for the interruption, Dan.
Thank you. Yeah, I think you answered most of those. So in terms of reporting it, you've got to strike a balance between what's realistic to be able to actually write down during a consultation without, having to suddenly add another 20 minutes to your appointment times. I personally don't get sort of bogged down by whether the patients reported it and whether I believe them or not thing. I would just report, 0 headaches, 0 dizziness, or no headaches, no dizziness. I would take for granted that me writing that in my notes makes the assumption that I asked that question, rather than me having to sort of explicitly write out the patient reported they had not had any headaches. And I would say that's sufficient, really, because we have to strike a balance between efficiency in our note taking and getting all the details down. So for me, without being able to quote any evidence to support that, putting no headaches, no dizziness, no paresthesia would be sufficient, I would say, without you having to sort of say the patient reported it or the patient denies it. I'm not sure that really is important, but I might have something I'll get back to you on. Just like you would put no weakness in the arm, you don't have to sort of say I examined the arm for its strength and there was no weakness. So I think when you write it in the notes, it's sort of taken that you performed that assessment, whether that assessment's a question or it's a physical assessment of doing the reflexes. That would be my take on it, Jerry. I don't know if you have any strong opinions differently, but that would be my take on it. Other questions? So in terms of a standard template, no, there isn't a standard template. I think because people take their notes in so many different ways, there are pros and cons of templates. If you become very reliant upon a template, then that can take away the specificity of your questioning to that patient, and it can become a little bit more of a tick box exercise rather than you following lines of inquiry because of the way a patient answered to the first question. It should be a little bit more algorithmic in the way that you question patients, and that the response to one question should open up a set of different questions depending how they responded. So I think there's a risk to relying on templates. But the purpose of this audit today will really be to get you to think about your case history form and decide whether there are perhaps any amendments that could be made to improve how you assess patients. What I don't think would be helpful is just to have this in a big list saying, have you had any paresthesia? Have you had any visual disturbance? Have you had any neck pain? Because if you just ask that of every patient, it will sort of dull your clinical thinking a little bit with patients, because you become reliant on that. That would be my feelings. Okay. So moving on to non-dissecting stroke. So again, the likelihood is you won't know, but just to present it in two slightly different ways, and probably the biggest difference that's often talked about is the trauma. So if you look at recent trauma for non-dissecting strokes, so this is where the lining of the artery isn't damaged, you've only really got 7% of these patients having a recent trauma versus 40 to 64% with the dissecting stroke. So that's often one of the main differences for these two. And you've still got lots of vascular risk factors, obviously. So, if their vascular system is in poorer health to begin with, there's going to be more risk of these serious consequences. So your hypertension, your smoker, your family history, oral contraceptive pill, that they're all still there. But it's that trauma that is much more of a feature of a dissecting stroke versus a non-dissecting stroke. Again, in terms of symptoms, we have headache featuring quite prominently, and also altered sensation or paresthesia, whether that's numbness, hypersensitivity, burning, tingling, whatever, in the arms and the legs. So don't forget, although you might be focused on upper extremity neurological symptoms because it's a neck pain patient and you're thinking about peripheral neuropathy, if we're thinking about vascular causes, then you need to include the lower extremities in a neurological assessment and consideration in questioning as well, because the patient is very unlikely to have attributed any changes or leg symptoms with their current episode of neck pain, so may not offer that when they're reporting their symptoms to you. So again, you'll see that things like loss of consciousness, they're quite low in terms of the incidence with these patients. So I know when I was taught, you'd always sort of ask patients if they're blackouts or fainted and things like that. Actually, that isn't really very, very common. It's going to be much more subtle things like unsteadiness and facial weakness, which we're going to have to test for. So a little bit of revision of the cranial nerves and assessing the cranial nerves, just the ones relevant to this. So trigeminal nerve, facial nerve, the muscles that move the facial muscles. Those are the ones that are really important to be able to assess. So getting the patients to pull all those funny faces, so that you can assess symmetry in the facial muscles, and then just having some questions that you can ask about speech and swallowing. Have you noticed any difficulties in your speech or eating and swallowing recently? And then you can add that to your case history. No changes in speech or swallowing. And then you're hitting a category of 70% of patients with a non-dissecting stroke would have that symptom, and you've identified this patient hasn't. So that can be reassuring. So obviously you'll get a copy of the PowerPoint and these tables. These tables don't feature like this in the IFOMPT framework. I've kind of condensed these to make them a little bit easier, but you'll have these in the PowerPoint. So I'm going to move on now. So physical examination, obviously from the information you've been given, physical examination is going to be really important. There's no one test you can do to satisfy yourself or anyone else that this patient doesn't have a vascular cause of neck pain. It really is a combination of the information you get from the case history and the information you get from your physical assessment that are going to determine the risk. There is no one test, whether that be blood pressure or anything else, that you can do, unfortunately. The physical assessments that are most important are going to be the neurological examination. So this is going to be your peripheral nerves, so the arms and legs, so your myotomes in the arms, myotomes in the legs, sensation testing in the arms, sensation testing in the legs, and then a cranial nerve assessment of the facial and trigeminal nerve for motor power to the muscles of facial expression and the muscles of mastication. Simple coordination and gait considerations. So that could be just observing the patient walking, observing them doing a simple sort of standing balance with their feet together and eyes open. Are they able to stand easily? You might do some simple coordination tests, stuff like you do for cerebellum testing. So this diadochokinesis testing, where they have to sort of turn their hand over rapidly on their palm, things like that. Or your clinical textbooks will all explain that. Blood pressure is another good one, just to gauge their current vascular health. In the guidelines is auscultation. So this is auscultation of the carotid artery. So this would be listening to the carotid arteries with a stethoscope. Jerry spoke to Steve Vogel about this, and apparently the evidence for this isn't particularly strong. And as a clinician, if you're not performing this assessment regularly, then you're unlikely to be able to pick up on the subtleties or know what you're actually listening for. So probably auscultation isn't something that should be relied upon. But certainly the others, neurological examination, coordination and gait, and blood pressure should be assessments you're relatively familiar with, and you should be sensitive to picking up changes in those from what is healthy. Risks and benefits of orthopedic manipulative therapy. So we can include osteopathy treatment there. This framework was devised for all physical therapists, so it doesn't specify osteopathy, but this is what we're talking about. So at the top, you've got a person with neck and or head pain. You've decided that there isn't a vasculogenic hypothesis. That means there isn't a vascular cause of their symptoms. So what we enter now is to person-centered shared decision-making. So we don't just assume that because it's safe to treat, that we treat. There's still the patient's decision as to what treatment and whether they have that treatment. And what that treatment might be, treatment you can provide, treatment that might be able to be provided elsewhere, or what would happen if they had no treatment. This is a discussion that ideally you'd be having with the patient so that they are able to input their own values and beliefs on the treatment that they receive, whether that be from you or someone else. So what you need to do is you need to weigh up the risks to them from having treatment or not having treatment versus the benefits of them to having treatment or not having treatment. And I'm going to provide a little bit of data so that you can make a more reasoned decision about that. So it's not your decision whether to give the patient treatment or not, but it's your role to provide the patient with the information that they need in order to make the decision about what treatment they want. And then, you can provide that treatment if that's a decision you come together with between you, that is the best option for them. And when you're thinking about risk, it's important that you think about the epidemiological risk versus the individual's risk. So the epidemiological risk, which means the risk to the population from receiving osteopathic treatment, is very, very low. So a patient receiving osteopathic manipulation to their neck carries about a 0.005 increased risk of a vertebral artery dissection. So it's almost negligible. That's taking it from 1 in 100,000 people to about 5 in 100,000 people will have some kind of consequence to the vertebral artery from receiving treatment to the cervical spine. So the risk to the population is very, very low. But you're not assessing the risk to the population, you're assessing the risk to the individual sat in front of you. And if that individual sat in front of you has had a recent trauma, dizziness, headache, family history of strokes, is on hypertension medication, has very high blood pressure on the day, and bilateral numbness in the arms, the risks to them having treatment to their cervical spine are likely to be increased much more than that 0.005%, because that individual poses a higher risk to a vascular event than the population in general, which is where this 0.005% risk comes from. So don't be incorrectly reassured that osteopathic treatment carries a very low risk. It does, which is great. But if you have a patient who is at high risk of a vascular event, then that patient is still at high risk of a vascular event, whether they have your treatment or not. And it's important that you identify that in order that they can get the best treatment. So these are the risks, and risks of other treatment are given just for comparison. So these are the adverse events. So a myocardial infarct, a heart attack, gastrointestinal bleed, or a stroke, so vertebral basilar artery stroke. So at any one time, the chance of having a heart attack out of 100,000 people is 2,400 people having a heart attack out of that 100,000 people. If you give those people anti-inflammatories, so non-steroidal anti-inflammatories, their risk of having a heart attack increases by about 6%. If you give, so the chance of anyone having a bleed is 87 out of 100,000. If you give them aspirin, their chance of having a bleed increases by 0.2 to 0.3%. The chances of having a stroke are about 0.79, so less than one person in 100,000. If you give them cervical manipulative treatment, the risk of them having a stroke increases by 0.005%. So it's negligible. It takes this to potentially 5, an absolute worst case scenario. It takes it to about 5 out of 100,000. So that's the epidemiological risk is very, very low. But you need to be assessing the patient in front of you, not just thinking about the risk to the whole population should you give them osteopathic treatment. Are there any questions on that? Because that's probably quite an important. No, everyone's good with that. Perfect. So clinical reasoning and shared decision making. What is shared decision making? And how do we implement shared decision making? So shared decision making fosters patient-centered care. So patient-centered care is care that is respectful of and responsive to individual patient preferences and their needs and values. And it ensures that patients' values guide all clinical decisions. So you're very much there to provide information to the patient in a way that they can access that information that's suitable to them and appropriate to them about them and their condition. And you're there to help facilitate them make a decision about what care they want. And then if that care that they want is a care you can provide, then obviously you provide it. But it's not just about you providing the care you do because they came to see you. It's very much about letting the patient lead the management of their symptoms. It might be that some patients come in and they're asking for a neck manipulation. That is what they feel they need, and they value that treatment approach. Other patients will say, I don't want you to do a neck manipulation with me. I don't like them. These are examples of patients demonstrating their values and beliefs. But we need to ensure that they have all the information in order to consent to treatment. Simply having a sentence on a case history saying, do you consent to treatment, and the patient signing it or ticking it, that isn't informed consent. Unless your case history form can prove that you provided the patient with the information they needed to consent, the consent is irrelevant because it wasn't informed consent. So getting consent is all about this shared decision-making process. And in order for a patient to achieve that, they need to have the right information. And for them to have the right information, you need to have collected the right information from them in the first place. So this goes back to this framework, which enables us to know where to focus our information collection as to what's relevant to the risks of vascular causes of neck pain. So as a clinician, you communicate personalized information. So again, it's not about using templates necessarily or having a spiel that you always give out. It's about making sure that the information you give that patient on that day is personalized to them, personalized to their history, personalized to their symptoms, personalized to their expectations and goals, the likelihood that treatment's going to work for them, what we know about the risks to them, and also what we don't know, being open about being uncertain and not necessarily knowing, this might get you better. It might be that actually if you did nothing, it would get better just as well. There are some risks from having treatment. Also, if you don't have treatment and your symptoms become chronic, that poses a risk because chronic symptoms are harder to treat. So, there are risks to not having treatment as well as to having treatment. And the skill is being able to communicate this in a way the patients going to be able to understand and act on. And one thing that was often taught, certainly I was taught, it was pre-treatment positional testing or vertebro-basilar testing. I think Maine's test was the name of one of the tests used. So should we abandon pre-treatment positional testing? Yes, we should abandon pre-treatment positional testing of the cervical spine. It has no use in clinical practice. It doesn't give us reliable results. You're just as likely to get a negative result with someone who has a problem with their blood supply as you are not to get a positive result with someone who doesn't have a problem with their blood supply. So the results are unhelpful. It can make you think there might not be an issue when there is, or it could make you think there is an issue when there isn't. So they really have no use. And potentially, if the tests actually worked, then the tests are actually reducing the blood flow in the arteries to the brain. So they're probably not the kind of thing you want to be doing with patients who might be at risk of a vascular issue in the first place. So they're really something that should be abandoned in clinical practice. And we should be using signs and symptoms, potentially carotid artery assessment, but certainly blood pressure and neurological assessment. So I've got a few patient case histories to go through, and these are just to demonstrate how patients might present. So we'll go through, we might only have time to go through one or two. So this is a 70-year-old lady presents with episodic neck pain and headache. She responds well to manual therapy in the past. This episode is described as severe and irritable, but like previous occasions, she has a history of hypertension, high cholesterol. She's had 2 previous strokes, the last one of which was 3 years ago. Yeah, are you concerned about any risk factors? Yes, obviously there's some risk factors there. Would you go ahead with a physical examination? Yes, I think we can say that, it's not going to be too dangerous to conduct a physical examination. So based on the limited information you've got for this patient, what would your support for a vascular hypothesis be? Do you think there's very low support for a vascular hypothesis, meaning that you don't think there's any risk of a vascular cause of her neck pain at all? Do you think there's a moderate risk in that there are some issues, but it's not going to be definite? Or do you think it's high risk in that you think it's almost guaranteed that there's a vascular cause? The pain is not unusual for the patient and it's not worsening, but a vascular hypothesis is worth testing, clearly because of her previous history. On examination, it looks like it's probably musculoskeletal dysfunction, but she does have some risk factors for a future stroke because she's had a stroke in the past. So what is the support for a vascular hypothesis? In this case, it was moderate. But certainly it's always worse to have a higher index of suspicion than a lower index of suspicion. So what's reassuring here is that nobody put low, because clearly there were risk factors within this patient. So, but there were also very good reasons why this could be another recurring episode of mechanical type neck pain. So what would you do with this patient? Well, hopefully what you would do is something called safety netting. So safety netting is where we put in place measures that the patient can act on should things start to develop that aren't what we expected. So if we're treating this lady for mechanical neck pain, we acknowledge that there is still a risk that there are vascular causes of her neck pain. So what we might do is put some safety netting in place where we say, we have a discussion, we explain what we think the cause of the problem is, we explain that there's still a level of uncertainty and it could always be something else. And therefore, if she starts to demonstrate any dizziness, any headaches, any changes of sensation in her arms, any facial weakness, difficulty chewing, swallowing, you might give her a list of the common symptoms of dissecting and non-dissecting events and give her actions to take if they develop. That might be contact you, contact the hospital, etc. So that's safety netting. We've got a plan A, but if that didn't turn out to be the cause, or we've got a diagnosis or a hypothesis of your symptoms, if that doesn't turn out to be accurate, this is what you need to do. And so you would need to put that safety netting in your notes as well. That's really important. you've got to explain the potential risks and benefits of the treatment, as we discussed, and that's the only way they can provide consent. Unless they know the risks and the benefits of treatment versus no treatment, the consent they give isn't informed. And so it doesn't matter whether they've signed anything, whether you've written it in your notes or not. If you can't demonstrate that it was informed consent, it isn't really relevant. We'd still probably try and conduct our treatment relatively low risk. So this would mean avoiding end range rotation, where there potentially can be mechanical implications for the artery, or extension. So we probably want to avoid provocative positions. So not just HVTs, we wouldn't necessarily want to be maintaining a neck in a position of end range rotation because we're stretching muscles. That could actually be more provocative than an HVT. So we just want to be thinking about minimizing risk all the time. And again, we might annotate that in our notes that we did that. And so patient D, 45-year-old man, 6-month history of gradual onset unilateral neck pain, more recent onset of headaches, pain's manageable, but it hasn't gone away. No history of trauma, no migraine, no cardiovascular risk factors. He answers questions focused on vascular hypothesis, so things like dizziness, numbness, etc. And they're all negative, and the pain seems to be consistent with musculoskeletal factors. Are there any risk factors? No, this one's pretty obvious. Would you go ahead with a physical examination? Yes, of course you would. What would you examine? All the normal things, and there's no real reason to start assessing neurologically here because there's nothing in the history that really suggests we need to. So I've not reset it because this one's pretty easy. So we won't go for this guy because hopefully it's fairly explanatory that this one is low risk. They're not worsening. There's no vascular dysfunction reported, no obvious risk factors. So the support for a vascular hypothesis is low. What would you do next? Will you treat them? And this would be your fairly standard treatment, hopefully. There's no real need for safety netting. There's going to be a much shorter discussion about risks because there just are fewer risks. You don't necessarily need to worry about avoiding end range rotation unless something gets picked up on the clinical examination. Any questions with those so far? I won't do the voting because these last two are... You were so good with the first one, and that was the only one that perhaps could go either way. These are the ones that are fairly cut and dry. So 33-year-old man presents, this is actually a real case, this one. So 33-year-old man presents with right-sided suboccipital neck pain and headache. Worst in the morning, aggravated by left rotation of the neck, all quite musculoskeletal so far. 2 weeks ago, after cricking the neck playing football, so this is potentially trauma. So this would be more your dissecting. No previous similar episode, no other health issues apart from migraines. So again, migraines is on that list of signs and symptoms. He had manual therapy 5 days ago, which was soft tissue to the neck, shoulders, dry needling into the traps, mobilization of the neck. He was immediately worse, increased pain and felt unsteady. So this unsteadiness, dizziness. When the dizziness settled, the therapist continued the treatment, but the patient became unwell again and vomited, so vomiting. So lots of these signs and symptoms that we had on our list earlier on. Would you examine the patient? Yes, you would, but clearly you would avoid things that are going to be provocative, such as cervical spine rotation and extension. Those are probably not the things you'd want to start with. You might want to start with the things that are going to be less provocative, but more informative, such as blood pressure, facial weakness, reflexes in the upper extremity, sensation testing, etc. We already know that moving his neck around isn't good for his symptoms, so we wouldn't perform that part of the examination. At mild restrictions in neck movement, no neurological or vascular tests were performed. This is when they saw the initial therapist. After the patient became unwell, the previous therapist performed functional positional testing. So this would be your sort of vertebro-basilar insufficiency testing, and it was negative, but we know that that test isn't very helpful. So what would you do next? This is the kind of patient that you may well get. They tried one therapist, it didn't work, so they go and try a different therapist because to them they still think they've got a mechanical neck pain, so they need to see a physical therapist of some kind. Really, with that information, we need to be performing the kind of examination that is more likely to reveal issues of a vascular nature, so blood pressure, facial nerve testing, trigeminal nerve testing, upper extremity and lower extremity neurological testing, so myotomes, dermatomes, reflexes. So hopefully you'd all be going with high on this one, so I will skip the voting just for time because we've got to move on to the audit activity. So this was unusual neck pain. There was a history of trauma. There was a history of migraine. These are all starting to give you a higher index of suspicion. The neck pain was worsening. You know, healthy young individual with a small minor trauma, that should start to get better. This was getting worse with therapy. So even if the initial presentation after his football injury wasn't vascular, it's certainly starting to seem vascular after he's had this intervention with this other therapist. So the support for a vascular hypothesis is high, and the appropriate action for this patient is going to be referral and investigation. Okay, so that's essentially finishing the presentation of the IFOMPT framework. And what we're going to do next is the clinical audit. So if there are any questions regarding the IFOMPT framework, please feel free to put those in the chat now. Otherwise, we're going to be moving on to the objective activity, the clinical audit. So this is where you'll need access to your patient notes, and you'll be needing to fill in some Microsoft Forms surveys again. So any questions or issues with accessing that so far, please let us know and we can try and help you.
The only thing to mention is a comment by Martin, who says that there is no category as no risk. It will always be low, you know, or medium or high, or intermediate and high. And just to make sure that it's clear in everyone's mind that, you know, no risk doesn't exist, and it's always, you know, the minimum would be low in the sort of category system.
Yeah, really good point. Really good point. So yeah, we can never be 100% sure. So that's why there is a no risk category. Absolutely. Yeah, good point. Lovely. Okay. So we're going to set the criteria. So we know we're using the IFOMPT framework, and we're going to be assessing different things. So we're going to be looking at the case history. Is there a possible cause, possible vascular cause for the patient's neck pain? So we're going to be looking at various components of the case history to see whether we've really demonstrated that we've done enough to identify that in our case history. Then we're going to be looking at the examination stage of the consultation. So what elements of vascular, neurological and physical examination were performed. It's not always necessary that a vascular and neurological examination would need to be performed. As you could see from one of the vignette examples, there's no indication to do a neurological assessment. So we're not saying that every neck pain patient has to have a cranial nerve and peripheral nerve neurological examination, but your case history information will guide you on that. And then what elements of patient communication are evidenced in your case history? Is there evidence of shared decision making? Is there evidence of discussions around consent and risk that would feed into that shared decision making process? Have you evidenced safety netting where appropriate? Have you given treatment? Was that treatment appropriate, or was referral more appropriate? And has that been evidenced in your case history notes? So this is what the clinical audit process is going to be looking at, really, and how more about our note taking, because our note taking doesn't always reflect exactly what happened in the consultation, and that's really where that example I gave earlier of that osteopath who was the result of an insurance payout, that's really where they fell short. It wasn't probably actually what they did with the patient, it was how they reported it afterwards that was the problem. So this big table here, we'll break it down for you. Basically on the left-hand column, there are 13 questions. You are going to ask those 13 questions of each of your case history notes. So the first question, are risk factors for vascular events detailed as present or confirmed absent? So in your case history somewhere, there's going to be probably in the signs and symptoms section and in the past medical history section, for example, there'll be an area where you might have recorded about whether they'd had a trauma to their neck in the cause of their symptoms. There might be an other healthcare sections where it might describe that they know they have a vascular anomaly, you know, they've been diagnosed with an aneurysm or something. that they can report that they've experienced migraines in the past. Their past medical history reports that they've got high cholesterol or hypertension, or their medication list reports that they're on the oral contraceptive pill, or they've had a family history of stroke. But equally, if none of those things are present, hopefully somewhere it says zero family history of illness, or zero medications, or zero other illnesses, or non-smoker, or if the patient did have, for example, a high suspicion of vascular causes, hopefully it does say somewhere no migraines, no dizziness, no paresthesia, because hopefully those questions you asked, if they had a higher vascular hypothesis risk, really. Second question, are clinical features for non-dissecting events detailed as present or confirmed absent? And then third question, very similar, are features for dissecting events detailed as present or confirmed absent? So that's really that list of signs, symptoms that we went through at the beginning, that table. So things like headache, neck pain, visual disturbance, paresthesia. You don't need to have differentiated whether they're non-dissecting or dissecting in your case history, obviously. But hopefully there's something that says, no paresthesia reported, no headaches, no unsteadiness, things like that, if it was a patient you were suspicious of. Has the support for a vascular hypothesis been discussed? So probably the concept of a vascular hypothesis, and that being low, medium or high, has only really been introduced to you today. So we're not expecting that to be in your case histories, but does it anywhere in your case history say, not concerned with a vascular hypothesis, or this patient, I'm worried about there being a vascular cause? Or do you have like a contraindications box, or a risks box, or a special notes box, and you can put in there possible risk of vascular issues to be concerned about? Is there anything that's suggestive of that? Question 5, has peripheral neurological examination being conducted? So there will be a not applicable section here because it's not always appropriate to do that. Has a relevant cranial nerve examination been conducted? Again, there will be a not applicable section for this because it's not always applicable. Has blood pressure been taken and recorded? Again, there'll be a not applicable section because it's not always appropriate. Has auscultation been conducted and reported? Again, it could be appropriate to put not applicable in all cases here because clinically you just don't feel that that's going to be a useful test for you because you don't know what you're listening for. Were cervical positioning or pre-manipulative tests used for VBI? Yes or no? Are contraindications or precautions to treatment listed or confirmed absent? So things like avoid end range rotation, avoid extension, if you were worried about there being a vascular cause. Is there evidence of shared decision making? So does it say anywhere in your notes you discussed risks and benefits of treatment versus no treatment, advised patient that this might resolve without treatment, but you said there's a small risk of X, Y, or Z, could just be increased pain, could be soreness, tenderness, fatigue. Was there any discussion about whether they were suitable or whether there were other options, whether perhaps they could try a different treatment and the risks of that? Is there evidence of informed consent? So, is there anywhere where it says that the patient consented to treatment in your notes? And is there any evidence of safety netting? So something that says at the bottom of the notes, possibly at the bottom of the treatment section, patient advised to get in touch if they develop headaches, if symptoms worsen, if they develop paresthesia, for example, or I will call the patient in 3 days to check on their symptoms, just so that you can make sure they've not developed any additional symptoms. So that would be kind of examples of safety netting. So in a second, I'm going to give you a link. I'll move on to that for you now. I'm going to measure the current data. So what are the standards? So when you're asking yourself the questions, you're going to have a few different response options. You can say it was fully completed. Yes, there was loads of details about signs and symptoms. I put which ones were present, which ones weren't present. That's full completion. Brilliant. You can also put partial completion. Okay, I might have put a little bit about consent, but perhaps there wasn't enough information to really stand up in court or that I'd be really comfortable about. So I just need to add a bit more detail, but it was mentioned a little bit. So I'm going to choose partial completion. Again, this is really for your benefit. So don't feel that you need to make it look better or worse than it is. It's really for you to act on. Illegible, if you've handwritten notes, you can't read it, or if you've typed something in, it's all garbled and doesn't make sense, you can choose an illegible option if you're not sure. And then missing or ambiguous. So if you've just left a blank, or it's just not present at all, you just didn't enter your head, or you did it but you didn't write it down, then that has to go down as missing or ambiguous. So those are going to be your response options to each of those questions that you're going to ask yourself. And then there's a not applicable for 5, 6, 7, and 8, because it might just not have been appropriate that you ask those questions. So Jerry's going to put the link in the chat, and then I can leave the questions up on screen, which might be easier for you. So this is the QR code, or you can type that in or use a link that Jerry puts in the chat. And what that will do is it will take you to a forms questionnaire. You need to use a different form for each patient. So once you've completed one form, it'll ask you if you want to do another, and you can, or you can just rescan the link again and then enter your next set of patient details. So hopefully you've got a few patients, ideally 5 would be great. And so we're just going to give you some time now to enter the details for all of those patients by answering those questions. And then what we'll do is we'll mix all that data up, so we'll be able to present all of it as a group, so no one individually is going to be identified, and it'll just say, okay, so for question 1, 10 of you said full, 10 of you said partial, 3 of you said missing, 2 of you said illegible, and we can just start to see how close we are to the framework for each of these areas. Okay, well done. So if you have still got some information to input, feel free to carry on. It will keep updating even when we're looking at the results. So don't stop if you're halfway through. Please carry on entering your data. So well done to everyone. That's a really impressive amount of data that you've managed to input. So that's excellent. So what we'll do is we'll just go through this now. So 35% of you went for full completion. So you were, a third of you were happy that your case history notes detailed that there was not only sufficient information if vascular symptoms were present. So yes, patients got dizziness. Yes, patients got paresthesia. That you were also recording this data when it wasn't a symptom either. I think that's what's important to recognize, that critical symptoms such as dizziness, history of trauma, paresthesia in the arms and legs, for example, they're really key to record as not being present, in order to demonstrate that your questioning was thorough and was giving consideration to vascular causes of neck pain. 47% of you went for partial completion. So clearly you are recording this data, but perhaps having looked at the framework, there are some symptoms that are perhaps more common than you thought that are associated with dissecting events. And now you will perhaps start to ask about those and record both positively and negatively whether they are present or not. A couple found that there were some illegible or ambiguous results, not many though, but around 16% felt that this was missing. So I suspect this is probably where the absence of symptoms has not been recorded. I suspect you're all recording the presence of symptoms well, but not the absence of symptoms, and so that's perhaps just a shift. So that might just be, for the purposes of a clinical audit, you might just want to perhaps have a practice meeting and discuss how do we feel it's best to record the absence of symptoms. What is an appropriate way for us to annotate that in our notes, or is there something we can program into our digital software system that makes this easier? How are we going to do this so it doesn't become laborsome and burdensome to record a list of stuff that's not there? Because obviously we're focusing on symptoms that are present, but nonetheless these absent symptoms are also very important. So, depending how you answered, that might be an area of focus for you to make a small intervention to try and improve your result. If you were in this 16% or 47% category, how can you get yourself into this 35% category? Our clinical features for non-dissecting events detailed as present or confirmed absent. So we've got around a quarter of you feeling confident that you're detailing all the symptoms as being present or absent, which relate to vascular causes. But we have got just over half of you who feel there is some missing data here. So again, a similar situation. It might just be about having a conversation with colleagues. How should we be recording this? Why are we not recording it? Is it because we think it's going to take too long? Is it because there isn't really space in the case history form? Is it because I'm not sure where it would be appropriate to record it in the case history form because I don't want it to get confused with the symptoms that are present or the positive test results that are present? So, you know, look at what barriers there are to why you're not currently doing this. Was it just simply you didn't know? So, you know, that's quite simple to change. Now you've been made aware, that's great. Have a think about that. Might be an area to focus on. Question 3 was very similar, and so the results are unsurprisingly very similar. Again, I just want to emphasize, I'm not really expecting you to differentiate between dissecting and non-dissecting. It's just that because the signs and symptoms were a bit different, I presented them in 2 different tables. The main one was really about history of trauma being the difference, much more common in one. Has support for a vascular hypothesis been discussed? So vascular hypothesis, that, you know, you don't need to have a section in your case history that says vascular hypothesis and then tick low, medium or high. And you could do, but you don't need to have that. And a vascular hypothesis, you know, that's just a terminology that IFOMPT use. Your case history just needs to demonstrate that you are giving consideration to the potential for this patient's symptoms being caused by vascular issues. So what's the easiest way for you to annotate that and communicate that? And so clearly for most of you, that isn't being communicated, because what you will currently be doing is you'll be interpreting all this information and then just deciding in your head whether there's a risk or not. But that needs to then be put onto your case history form, that you've had that thought process in your head and made the determination that it's low risk or high risk or medium, if that's an easy way to categorize it into those 3 categories for you. Has peripheral neurological examination being conducted and reported? So that's not always necessary, because the patient might be low risk and not give any indication of your neurological symptoms, so you don't need to do it. So that's why I've got not applicable. So in around a third of your patients, this wasn't applicable. But it's either missing or partially completed in sort of 40% of patients. So potentially these are patients that should have undergone a neurological examination, and it's either been done and not recorded fully, or it's just not been done. And really, there were suggestions elsewhere in the case history that would have been an appropriate examination. So again, these are discussions that you might want to have with colleagues as to why is this neurological examination not being done? Is it I'm not really comfortable with how to do it, or it takes me too long, so perhaps I need to just refine it and make it a quicker process? Is it that the equipment's a pain to get to because it's always in the other clinic room? You know, there could just be really sort of simple reasons why it's not being done. And so it's just a case of stepping back and having a look, you know, what stops me from doing that? Is it more sort of practical aspects, or is it that I didn't appreciate that was such an important examination, or is it just that it takes me too long? You know, how are you going to get rid of those barriers to enable you to perform that test more easily? Same sort of thing for the cranial nerve examination. In half of cases, it wasn't really appropriate. Hopefully now you're confident in whether it's appropriate or applicable or not. But we've still got sort of 40% where perhaps it should have been done, and if it was done, it wasn't recorded properly. How do we record our cranial nerve examination results? I did it, but then I don't really know how to record it because it's a bit of a weird one. So, you know, perhaps I need to come up with a standardized way of recording for cranial nerve 5, cranial nerve 7, you know, motor and sensory testing of those nerves. Is there an optional box that could pop up on my clinic software that would make that easy to fill in? Or do I just need to decide on some annotations that make it easier for me to record that in my handwritten notes, not having to write great big long, well, I stuck a cotton wool in their eye and stuff like this? Has blood pressure been taken and recorded? So that should be an easy test to do. Still missing in a third. So, now you've got these electric cuffs, you can get decent validated electric cuffs. You can stick them on while you're doing something else, and it's taking the blood pressure for you. So time shouldn't be an issue. We just need to buy one of these fancy cuffs rather than I've got this old mercury thing that's hard to get out and is a real faff. So, what are the barriers? Why is it you're not doing the blood pressure? And it might just be a simple thing of getting a new cuff and keeping it in the drawer so it's easy to do with patients. That's the only intervention you need to do, and then you can see a change when we do this again. We're not asking you to make all of these perfect. Just pick one of them and see if you can think of something to improve one of them. Has auscultation been conducted and reported? So yeah, I mean, this is not something I would do. So yeah, if you're happy that you can do this competently, then that's great. But for most people, it was missing. Again, it's not something I'm suggesting you start doing. But it is in the guide, it is in the framework, it is in the guidelines. But I think for most people, it's going to be more appropriate to focus on the neurological examination and the blood pressure and the case history, the quality of the case history. Was pre-manipulative testing used? So for most people, they're not using it. That's great. Some people are still using it. So we've got potentially 12% of people using pre-manipulative testing. So there are links to some research about the pre-manipulative testing. So I'd invite you to read that to make a decision on whether you feel it is an appropriate use of your time and whether it's a safe and effective test to use. Are contraindications or precautions to treatment listed or confirmed absent? So in partial completion, 39%, illegible or ambiguous, or missing 36%. So 80% of these are not listing contraindications or precautions. And I think this was something that I added when I did a similar exercise. Is we added a contraindications box that became a compulsory component that you had to fill in, so that you had to write no contraindications to treatment if there were none, or you had to obviously fill them in if you did. So that can be something that's easily improved by adding a prompt, and particularly on the digital software, you can make it compulsory. So a clinician's got to put none, and then they've committed themselves to those no contraindications with this patient, which they're unlikely to do if they do have any concerns. So it does prompt you to fill that in a bit more detail. Is there evidence of shared decision making? So we've got around just over a quarter of people happy that they can evidence shared decision making's taken place by what they've written in their case history. I mean, I'd be very surprised if shared decision making isn't taking place on a very regular basis with all of your patients. But recording that process is a different challenge. And so I think that's why we've got quite a high percentage who've said it's missing or only partially completed, because the challenge is how do you record that? And so these are discussions to have with colleagues, reflections to have on your case history notes, reflections to have on the conversations you have with patients, and how best to capture what's been discussed in a way that's not going to be too burdensome to record in the notes. Is there evidence of informed consent? And again, that's not just you writing patient consented to treatment or patient consented to examination. It's about that previous question 11, where there's some evidence of shared decision making. There's some evidence of knowledge transfer, of information transfer, where you've been telling the patient about their risks, the benefits of treatment, the benefits of not having treatment, the risks of not having treatment, perhaps recording some of their opinions. Patient didn't want this, patient did want that, patient's worried about this. That's the evidence of the shared decision making, which then means that if they have given consent, that consent was informed because they had the information necessary to give consent. Safety netting, the last one. So this was where you're putting something in the notes that says, I'm going to ring the patient in 3 days because I'm a little bit worried about them, but it was safe. Things felt safe enough to give some treatment, but just to make sure that nothing develops. A bit like that vignette, that last vignette we had where the symptoms developed after treatment. I'm just going to check in with the patient in a few days, make sure they've not developed any new symptoms, make sure they're responding well to treatment as I would expect, so that if they're not, I can intervene sooner rather than waiting a week or two for their follow-up appointment. So not applicable. So obviously this wasn't necessary in around a quarter of cases because the patient was low risk and didn't really need that safety netting. But potentially we've got, 70% of patients who really perhaps would have benefited from safety netting, or it's quite possible that you said those things to the patient. You said, give me a call in 3 days if these symptoms don't improve. That's something that's quite common. That's safety netting. You've done safety netting, but put it in your notes, and then you've evidenced it. I'm sure it's things you do. I'm sure it's things you do. I'm sure you say, look, if the symptoms get any worse, give me a call. That's safety netting. If you develop any numbness, if the numbness gets worse, if you start to get weakness, call me. That's safety netting. Okay, any questions from those results? Anything particularly surprising? So this is pretty standard from what we've seen when we've run this elsewhere. You can get a copy of your own results. We're going to keep these results, and then essentially what's going to happen is in a few months' time, we're going to invite you just by email we're going to provide a link in an email for you to complete this survey again with another 5 patients that you've seen since you've changed something. And we'll just compare the results after you've changed something to these results. And hopefully we'll see that these partial completions and missing sections get a bit smaller and the full completion sections have got a little bit bigger, because hopefully your clinical audit has served its purpose and it's helped you achieve better patient care, basically. So
can I just say, Dan, that will be done on your own time. So we will send you an email to invite you to fill in this data, but we want to have a live webinar like this. So it should be easy for you to fit that in with your clinical work. And the aim is for you to also report which intervention you will have implemented to try to change some of these factors.
Yeah, so hopefully you've got enough information now to decide what you think you need to focus on. Obviously, we're not suggesting you try and tackle all of those, so you're getting full marks on all of those, but perhaps pick one that you felt was perhaps where you scored, less successfully, or you've identified an area. Have a think what you could do about it. So I've sort of suggested some areas that are common barriers to why these things aren't getting done. Who's going to do it? Is it you? Is it something that perhaps needs to be with colleagues? Is it the practice principal perhaps needs to have a look at the software system and make some changes to the case history? Is that a discussion you're going to have with them? Is it where they keep equipment? There could be various reasons. It's really to go back and reflect using objective external opinion, because we've kind of had this kind of group think now about what we're doing. So we've got that, we can compare ourselves to other people now and say, okay, answer the guidelines. Look, I really need to be working a bit harder here. What's stopping me achieving that? What do I need to change? Have a think, how are you going to do it? When you're going to do it? And then we're going to do a re-audit. So we're going to probably, and here's the resources. So this is I'll send out to you. So you've got the IFOMPT framework, and there's a link here. It's quite a big document. So there's also a position statement on the IFOMPT framework, which is a bit more accessible, a bit shorter, a bit more concise. So it might be you want to read that. There's also a nice position statement on red flags. They're not really as black and white as we thought they were when we were trained, and they're not really as helpful as they used to be. That's quite useful. There's information on how to record your CPD if you've been struggling with that. And there's also some guidelines on hypertension. So when you're taking this blood pressure, how do you actually interpret the results? When is it hypertension? When should you be doing something about it? What should you be doing about it? And there's guidelines on how to do an audit. There's research on the pre-manipulative testing. There's some nice videos on how to do upper and lower extremity nerve examinations, how to do cranial nerve examinations, how to auscultate the carotid arteries, if that's something you want to look at, what it sounds like when you've got a bruit in the carotid arteries, how to take blood pressure if you're a bit rusty on how to take blood pressure. So there's quite a bit of CPD you can do there as well about all those clinical skills.